Hello, Raksha.
Hello, ma'am. Hello, ma'am.
How are
Welcome back.
you?
Yes, ma'am. I'm fine.
कहाँ बेस्ड हो आप?
I'm in Bangalore, ma'am. I'm from Bangalore.
गुड
Uh,
आफ्टरनून मैडम, खड़से मैडम.
Yeah, hello.
Good
Good.
afternoon, ma'am.
Good
Sandhya, ma'am.
afternoon. Good afternoon.
So, sorry, Raksha, I was asking, where are you from?
I'm from Bangalore, ma'am.
Oh,
I am from
Bangalore.
Bangalore. I work at Dayanand Saga Medical College. I work with Dr. Asha Benkappa, ma'am.
Okay.
Uh,
You're a pediatrician.
I am a pediatrician. Yes, ma'am. You are from Pune, no, ma'am? Pune, I read.
And madam is in Navi Mumbai.
Correct. I read her. Mm.
Me and madam very old friends. We do
Yeah.
a lot of activities together.
Very, very nice, ma'am. I think now we'll be starting with initial introduction.
Yeah.
So after 30 minutes, our program will start, that academic one, ma'am. Huh?
Okay, that's fine.
Mhm.
So just few minutes, then I will make my video off. Huh?
Yes, ma'am. Yes, ma'am. Once they join, I also joined little early. Like I thought, what
Good evening,
it
Dr. Sandhya Katshe.
Yeah, yes, sir. Namaste, sir.
Namaskar, namaskar.
Namaskar.
Namaste.
Namaskar, Mangla madam.
Namaskar. How are you?
Okay, I'm in Westport, Connecticut for 6 months as a green card holder.
Okay.
I'll be returning next month.
Oh,
Okay.
what are you doing there?
No, because green card, I have to come. My daughter is a cardiologist.
Ah,
University. Son-in-law is intervention leader. Madam, Neelam Mohan, madam.
Hello,
Yeah.
Good evening.
good evening. I've come somewhere out too. So I'm just trying to make seat comfortable. इस साइड को दिख रही है ये इधर खड़े रहे तो इधर इसको पकड़, ये छोटी कुर्सी है हल्की, इसको खींच जरा यार, ये इसको हटाने नहीं यार, वजन यहाँ ये डस्टबिन
Good evening, madam, and good evening, Asha Benagappa.
Good afternoon, everybody.
hello. Good afternoon, madam.
Good afternoon.
How are
Good
you?
afternoon, ma'am.
Very well. Just getting the positions right. Which is the okay? I think this would be better. Is the AC working?
फिर रोज रोज आता 7 दिवस
I think let's start sharing. If anybody, you all should share in other groups. IYCY yesterday, not a single person posted. In the night, I saw and I was zapped and shocked that neither in IYCI main, neither in social nowhere, they posted this and link. I mean, I have no idea why, but it wasn't. And everything else was posted except this activity, which really intrigued me. Raksha and all, please take care of your work. Please post everywhere.
Yes, ma'am. Yes, we'll do.
IYCOF, you know, the आधे लोग तो वहीं से थे. I mean, most of you all are there. Then how come you didn't post the link there? I don't know. Okay, let me post in the EB group.
Madam, I'm a gynecologist,
Thank you.
and yeah, I'm in the one of the IYCF group.
No, yesterday I was just saying that none of the pediatrician posted, you know.
That's
Which is not
surprising.
fair.
And
Very
particularly when
surprising.
you are there, it is
Then
even.
that's what togetherness, how will it come when we are not together?
Good evening, Dadish.
Good evening. Good evening.
How are you?
I am fine. Great. Thank you.
Thank you. Good evening, Dr.
So
Rajagopal.
many stalwarts there in the meeting.
Good evening, Dadik sir.
Yes. Namaste, madam.
Yes.
Good evening, Dr. Malik, Sushma Malik ji, madam.
Good afternoon, sir. Yeah, good evening.
Good afternoon.
Yeah, good afternoon, Mangla ji, Sandhya.
Gadich, you have put on
Dr.
lot of
Neil,
weight. Please go on low
Yeah,
carbs
Dr. Asha.
from our BPNI days to now.
I'm trying to reduce now. Good afternoon, President Madam, Dr. Neelam.
Very good
Namaskar.
afternoon. I was trying to connect you yesterday. Then I gave a message to them to please convey to you that it is a personal message. Hope you got
Yes.
it.
Yeah.
Good afternoon, Dr. Neelam. Good afternoon,
Hello,
Mangla.
madam. Hello.
Hello.
Hello, good afternoon, Sushma.
Good afternoon. Good afternoon, Dr. Asha, Dr. Sachi.
Good
डॉक्टर
afternoon.
संध्या मैम आप भी अपने वहाँ महाराष्ट्र में 2-4 जगह पोस्ट कर दो मैम.
Sharur, madam. Immediately. I will.
Everybody posts in different areas.
Yeah.
Saji, are you posting in the all the president secretary groups?
I have
Saji?
posted in the WPF groups.
Saji,
You have posted already.
Yes, ma'am.
can you kindly post in that 2026 all north, south, east, west?
Yes, yes. Posted, madam. Posted.
Thank you so much.
2026, 2025, 24 all posted.
we will need to start now. Ganesh Kulkarni, are you there?
Ma'am, Ganesh sir, he
Who's
said he has.
who's the
I
MOC
will be
today?
doing, ma'am. I
So
will be doing that.
it is 3:30. You can ask Dr. Saji to go YouTube live because nurses may see through YouTube. We
Okay,
posted
ma'am.
YouTube to them.
Okay. I will just put a message and start with it.
No, I'll tell him. Saji, please go live.
Yes, ma'am. Give me a minute.
Good evening, Mallikarjun.
Start, ma'am.
Good evening, Dr. Mallikarjuna.
Sir,
Yeah, we've
Srinivasan sir,
started,
namaste. Neelam madam, namaste.
Namaskar.
We've
Sandhya
started.
madam, Pradeep
We've
sir,
started.
all of you, good afternoon and namaste.
Over to the MOC, please.
Yes, ma'am. Good afternoon, everyone. I am Dr. Raksha. A warm welcome to all our respected dignitaries, faculty members, and healthcare professionals, including doctors, nurses, and lactation experts who have joined and who are watching through YouTube. It's my pleasure to welcome you all to Day 2 of the World Breastfeeding Week celebration webinar, which is being organized in combined effort of IAP, NNF, FOXY, and ILC. So yesterday we reflected on NFHS 6 statistics and how to tackle worsening trends in breastfeeding in spite of our good effort like institutional deliveries and early breastfeeding. So in spite of that, why it is falling, that's what we discussed yesterday. Today, in keeping in line with today's theme, safe feeding and feeding practices and avoiding harm, we will be discussing about bottle feeding, formula feeding, how to tackle them, and IMS Act. That's what today we are discussing. So once again, I extend my heartfelt welcome to each one of you and thank you for your presence and enthusiasm. Now I would like to request Dr. Ruchira ma'am, Ruchira Maheshwari ma'am, if she's there, to address the gathering and give welcome.
Okay, thank you. Thank you, Doctor.
Raksha.
Right, thank you, Dr. Raksha. So it indeed is a pleasure from Indian Academy of Pediatrics side to welcome you all, the august audience, for this great initiative which our president has started, this alliance of 4 organization working for breastfeeding promotion, empowerment, and education. And I'm sure that this 7 days bonanza will definitely make some dent in the practices of breastfeeding in the country. Thank you very much. Over to
Thank
Dr.
you, ma'am.
Hudson.
Thank you, Ruchira ma'am. Now I invite our dynamic IAP president, Dr. Neelam Mohan, to address the gathering and let her introduce the guest of honor of today, Dr. Dadit sir.
Thank you so much, Raksha, and it's indeed a pleasure on behalf of Indian Academy of Pediatrics to say that despite our efforts, breastfeeding rates, what we envisage, are dropping down, especially the exclusive breastfeeding rate, and also concerns are being raised that only 1 in 2 babies are getting early breastfeeding. It is envisaged that probably the stakeholders are not able to communicate in the same voice. Where are we going wrong was a matter of concern. So this is an endeavor wherein all the societies, we came in together. And I'm very grateful to my partner societies who on one call decided to come together with IAP for this noble cause, wherein the FOXY, the Nursing Association, as well as the NNF, besides IAP, are coming together. And we will also come out with a position statement on 4. And in that position statement, you will see that other stakeholders have also been involved, like the preventive and social medicine, and including other NGOs who are working significantly in the country in this direction. all of them have been coming together, including AIMS, to say what best we can do and address in this one voice, one mission, and one message is what we want to give. And that message is, let's all work together to promote and support mothers for breastfeeding. It is the responsibility of not the mother, but it is the responsibility of the family. It is the responsibility of the community, and it is the responsibility of the healthcare professionals at large. And therefore, besides this, it is definitely that we would expect the administrative role of government also to come on. And we are trying to understand where things are going wrong. And in this, today we have great two people come over. We have chairpersons, and I'm assuming you will introduce. We have seniors, not only Asha Benappa, who was in the convener, but we have Sushma. We have today Mallikarjun Ji with us, who's the chairperson, and we've had Dr. Dadit. Dadit is going to be with us. His work has been talked phenomenally, his contribution in breastfeeding. And when I get to hear about it, I know that Dadit, even Vida ma'am was talking very high of his work and contribution in this field. And therefore, today it's a pleasure that we want the country to understand that we are all coming together. It is not about an individual. It is not about a chapter. It is not about a society. It is about us as healthcare professionals, as good citizens. We need to come together to ensure that there is good growth of children and nation at large, and we reduce the metabolic health diseases load in adults by switching on to early breastfeeding and exclusive breastfeeding and understanding the importance of this Amrit. Thank you once again for this opportunity, and I express my gratitude to all the other forums who have joined us, and I would hand over to the MOC to take this forward, Dr. Raksha.
Thank you, ma'am, and thank you for bringing multiple associations together and conducting this wonderful program. And welcome to Dr. Dadit sir. And I request Dr. Dadit sir to speak few words and address the gathering, sir.
Thank you, Dr. Raksha. Thank you, Dr. Neelam. It is indeed an honor to be invited to today's program, and I sincerely thank the organizing team for this opportunity. I will take only 2-3 minutes because I know that a very good, excellent program is lined up for today, and I will not come in between the excellent speakers and the audience. Friends, every year we observe this week, the World Breastfeeding Week, for many, since 1991, I think, and between 1st and 7th August. But what I find this year is that this year is truly historic. And what makes it historic? It is the launch of the Breastfeeding Alliance 2026. This was long overdue, actually, because when we have every partner coming together and at national level, and this time Indian Academy of Pediatrics, National Neonatology Forum, FOGSI, and Indian Nursing Council, they are coming together to have this alliance, and this is really historic. I congratulate the leadership of all 4 organizations for taking this important step. It reflects that they have recognized that improving and sustaining breastfeeding, it requires coordinated action, it requires shared responsibility. Alone, a pediatrician cannot support a mother. The obstetrician, the neonatologist, the nursing staff, all of them, they have to come together. And the task is cut out for this alliance. Recently, we had an FHS6 data available to us, and there were some good news, but there are some news which concerns us. Good news is that after hovering around 41%, the initiation of breastfeeding is now crossed 50% mark. Still, there is a long way to go, but the good thing is that it has started moving now. But the thing which concerns us is that the exclusive breastfeeding, which was 65% or so, and we were very proud of it. I mean, among many other, in comparison to many other countries, we were way ahead, but it has gone down. So this is real cause of concern. It shows that mothers, they are supplementing other things before 6 months, and maybe they are not getting adequate support both at hospitals and in the community, in the families. So we need to recognize this, and because they are coming to us for deliveries, and after that for care of their babies, they are coming to us, they are having number of contacts with us. So this is our duty to support these mothers so that they stick to the exclusive breastfeeding. I have a suggestion here. At national level, we have this alliance of 4 organizations, but I think this should percolate down. There should be state alliances, there should be district alliances of these 4 organizations. Maybe Indian Nursing Council may remain there as the national organization, but all the rest of 3, they should have state and district. And also at hospital level, there should be a breastfeeding committee in which there should be the pediatrician and neonatologist, there should be the obstetrician, there should be the nursing superintendent, there should be, even I would say, there should be the head of anesthesia, because if you want to do anything in the operation theater, then you should also take them in confidence, and anybody else, and the administrator, so that all these people, they should have the hospital breastfeeding committee, and they should identify in their own institute what are the barriers and how to tackle those barriers, what steps are required, because many times we find that the barriers are very small, they can be removed even with simple administrative action. So all these things can be done at the micro level. So this will be the real benefit of coming together at national level. We know that the leadership has the intent, and this can be transferred to the state, district, and hospital level. While we are discussing the supporting mother, we should also recognize, take cognizance of risks of formula feeding. We are discussing it today in this webinar, the implementation of the IMS Act, but we should also look into the conflicts of interest, because what we see is that there is a growing trend of doctors, including pediatricians, neonatologists, and obstetricians. They are collaborating with the baby food companies. They are there in their social media pages, Instagrams and Facebook and all those things. And in a way, they are giving undeserving professional legitimacy to these companies. That should stop, actually. This is a classic example of manipulation by association. It was recognized long back, and from our own country, Dr. R.K. Anand worked a lot on this subject, manipulation by association. So I think since we have come together, we can discuss it out, and this alliance, it can take a very firm and unequivocal stand against such practices. So with these thoughts, I conclude, And I look forward to listening to the distinguished speakers and learning from their insights. And I wish today's program every success. Thank you very much.
Thank you, Dr. Dadich. That was very very proactive message, and I hear you. But even to get this together, I'm realizing that the support is not as much as I would want to, and I'm being very candid with you. There have been ages when everybody's theoretically working, but you need to understand if we failed, then what is the voice? Are they too sometimes our voices are not very right when we talk about arrogance with the mother, the system. If somebody is needing feed, for example, and inborn errors of metabolism, they were also not getting their product because we tried to become like a strict, and we didn't empower, we didn't embrace people as we went. And like you treat an adolescent, you need to listen to them and then give her. So I think somewhere this is what has happened, and people forgot to involve everybody in breastfeeding. And I'm making huge efforts, and I need people like you to come over because if you form a congregation with all the others who've joined, then we can obviously disseminate and quickly put this into the states and alliance. But what I wanted to say is we need to remember that it has to come from the state. I mean, I'm here only for a few months, so it's like there or not, but I'll continue to be a member of the IAP and the chapter and everybody. So it's not only the responsibility of the chapter where somewhere we forgot. It is breastfeeding is involving every pediatrician, irrespective of whatever field you are. You may be doing pediatric derma, doesn't matter. But that the concept that is there, I need people like you to come out and talk in voices that it's not about few people, it's not about chapter, it's about IAP jumping down and, going hand in hand with the chapter till everybody gets. That's my thought to you, and give it a thought. And I would request, I think I saw a big name there, Dr. Anand, JB Anand. I mean, I've heard a lot about him when it comes to. So Sushma Ji, since you would have known him much better, may I request you also to share a few words for him?
Can I say
Thank you.
30 seconds?
Yes.
30 seconds if you can give me?
Yes, that I
30
need to
seconds.
hear from you.
Yeah.
Yes.
Yeah, I think the idea should be that a mother should be kept in center actually. And when we keep mother in the center, it's not only mother's responsibility. The responsibility is should be shared by all of us, those who are dealing with the mother. And when I heard about this alliance, you won't believe me, but I became nostalgic because in early 90s, when the country was implementing the BFHI program, 14 organizations, they came together actually to implement BFHI. The secretariat was at IMA headquarters. So I think people can come together. I mean, it's a good cause. And we all know, we have all signs available to us. The tagline which says that strengthen what works. We also know what works. So until unless we come together, it will not be. I think we will not be successful in this. Yeah.
Thank you so much for reaffirming that. Thank you.
Thank you, Dr. Dadich, and thank you, Neelam, for asking me to introduce the great personality, the respected Dr. R.K. Anand. He has joined us despite his being a nonagenarian in his 90s. His commitment to breastfeeding has never ever stopped. He is the stalwart, who started off with the BFHI movement, the IMS Act. He's played a role in bringing the breastfeeding movement in the last, I think, not just 30 or 40 years, I think 50 years. He's represented India, not only in India, but even abroad. He's been very active with BABA, with UNICEF, and he's done phenomenal work. Pranam and namaste, sir. If you want
Can
to
we have a
unmute.
spotlight on him, Saji? I mean, how do
Yes.
we,
Yeah.
can we see?
Sir, I think your son has helped you to join. I don't know if
Yeah, I can see
I
that
think it is.
name, but I
Yes,
can't.
R.K. Anand.
Okay,
Yeah,
whenever he
I'm not
joins.
sure. Yes,
will
he's
we
there.
see?
He's very much there because for
Yeah.
some time the video was on, but I think the son has put it on. I'm just trying to see if his son is there and I can
But in the
ask him.
meantime,
But
we'll
we'll start
continue,
off
Dr.
with our
Sushma.
yes.
We
Yes.
over to the MOC, Raksha.
Yes, ma'am. Thank you, Dadit sir. That was a wonderful address and words of wisdom. Thanks for those. And now I request Dr. Singarvelu sir, President-elect, to speak few words addressing the gathering, sir. Dr. Singarvelu sir, are you there? There. Yeah, I'm not able to see his name. So we will just move ahead. Once sir joins, we can ask him to speak. And I now request President of other organizations from Foxy, Dr. Bhaskar Pal sir. If you are
I
there.
think today Dr. Bhaskar is not there, but on his behalf, there was another madam from the Gynae, and then NNF we have Amit, who's also a panelist.
Any of them are speaking, ma'am, now, like Lalan Bharti sir, Dilip sir?
No, I think they'll speak on 4th now.
Okay. Thank you, ma'am. So now I also acknowledge the presence of Dr. Mallikarjun sir, Honnali Banaji Mallikarjun sir, who is chairperson for today's program. Sir, if you are there, you want to speak few words, can you
And
please
after
address?
that, Amit is there. I can see him. He can give his message from.
Good afternoon, everyone. I'm here, madam. Thank you very much for remembering me and including me in this program, madam. Already so many, chapters and specialties have come together, rightly said by Dadit sir. Mother-centric. So already from traditionally our culture is mother-centric because in my home and village, it is the mother and the grandmother who dominated. Fathers had a role of earning and sharing. Otherwise, final decision was made by the mother and the grandmothers. So in this context, putting the mother in the center, and in addition to what Dadit sir has told, involving for training in the medical colleges, madam, that I would still put it as the top thing because simultaneously everything is being one message, one voice, one forum. Everyone has come together here. Same way, I want the uniform training for all the medical colleges simultaneously would narrow down the different way of thinking, school of thinking as one unified way of putting IYCF breastfeeding into one. Today's title, what we all have given is one mission, one message, one voice, one platform, oneness, and one way of doing it. It will give remedy in the long run. We put the 7 days TOT training program minimum in all the medical colleges under the NRHM funds by Government of India, bringing ICMR together so that research material can be generated, and also NMC together will go a long way. One investment is required, we can get almost 90% solution to it. 10 years down the lane, all the medical colleges will be running IVCF clinics, lactation counselor courses, fellowships, where in one point where anesthetist, gynecologist, obstetrician, pediatrician, the nursing and the community medicine people work together, community clinics to hospital clinics, institutional clinics, nursing people are trained. The whole healthcare and the supporting system is empowered well, trained well. Because see, we have got different ways of treating the same problem by different people. So all that will become one language, oneness, unified version. And the module is very powerful. We know that baby breastfeeding hospital friendly trainings are going on. and we want the next training to be done. It is only after August 2027. The bookings are so high now, people are coming forward. It's a good move. I think under the captaincy and then leadership of Neelam Mohan Madam, it can be taken forward, which will solve all the problems. NNF has a major role because all the NICU babies are the ones who maybe, at the, priority of giving sometimes the milk, where we need to educate mothers from antenatally, then empower them during the stay in expressing the milk, then making it happen. All that works wonderfully, madam. This is my message, so that once we have come together in this platform, let us do it more. I think our Neelam madam can do it in a larger version for the country, madam. With that hope, I wish all the best for this program. Special thanks to inviting me and requesting me to be the chairperson of this wonderful program, madam.
I
Thank
would
you.
request you, Mallikarjun, to continue to be a part of it, like many people who are like-minded have come together. And I want people from all speciality, from all walks to come in and take the responsibility in various states, as beautifully highlighted by Dadej. I will be more than happy within next week to make you all the coordinators in a given place so that you can brainstorm, steer wheel and see. And fortunately on 4th, you'll have the additional commissioner of Ministry of Health and Family Welfare, who's going to join us, Dr. Pavan. And I'm going to put forward all these plans, what you're all saying. So I've heard you and I've heard Adik, but it would be nice you can send me a message also so that I can acknowledge you all for that. We need to see what best. And sometimes I loudly say that whoever is the naughtier person, we should rather make the person monitor of the class so that everything goes in order. So maybe we should see where are we going wrong and then do it together. Maybe we are hitting the pediatricians too much. What exactly are we doing that they don't like? What exactly we should do? Something we should learn. Like yesterday, there was a very beautiful learning. Instead of just getting into a room and saying, "Hurry, how are you feeding the baby? If you feed like that, the baby will aspirate. Is this the way to do?" Instead of that, she said, you should say, "Oh, you're doing a good job, but maybe if you keep the baby in this position, it is better." What a way of saying it. So maybe that's the way to talk to the family, to the pediatrician, to the parents, to the gynecologist, to the nurses. They're all very much work stressed and they don't have too much of time. So how it needs to be communicated, a strategy with those 10 or 20 commandments needs to come out with all of you put together. All who are participating in this meeting in 7 days, don't think your job is done. It is the beginning of the journey for you all to steer it. Hum rahe na rahe, you all have to take it forward. Thank you so much, Dr. Mallikarjun.
Thank you, Mallikarjun sir, for the speech, as well as for being the strong advocate for breastfeeding and your dedication and work in that field. Thank you. And now moving on, I want to introduce our panelists for today's academic discussion. And then we will, if anyone wants, I'll request them
Start
to
the
speak.
session, Raksha. We're already 4 o'clock.
Yeah, please
People are
start. I
waiting.
want to say the same thing to you.
Okay, ma'am. Okay. So, yes, ma'am, we will be starting the academic session. So, our today's panelists being Dr. Sandhya Kadse ma'am from IAP. She is a dean, MGM Medical College. And then we have Dr. Mangalavani ma'am. She is a gynecologist and she is a lactation consultant. And then we have Dr. Manju Vatsa. She's from INC. She was the principal of Nursing College, AIMS. And we have Amit Upadhyaya sir. He is from NNF. So let me just share this one. I will not be speaking anything. Yes. So this is Professor Dr. Sandhya ma'am, Sandhya Satish Kadse. Then Dr. Mangalavani, ma'am. Amit Upadhyay sir, and Dr. Manju Vatsama. So, with this introduction, we will be moving on to the academic session. So, we'll be starting with 10-minute lectures followed by panel discussion. Now, I invite Dr. Smita, senior resident from Dayanand Sagar Medical College, to speak about harms of bottle feeding and formula feeding. Smita, can you please share your PPTs?
Thank you, Raksha ma'am. Good evening, everyone. I'm Dr. Smita Shalini from PRCD Cymer, Bangalore. I'll be talking about the harmful effects of bottle feeding and the formula feeding. I'll be sharing my PPT. I would like to thank Dr. Asha ma'am and the Dr. Neelam Mohan ma'am for giving me this opportunity. Today we'll be discussing about the harmful effects of feeding aids, formula, and the human milk fortifiers. First coming to the formula feeding. Uh, a- as a pediatrician, we have seen struggling the new mothers. Whenever they struggle, the first voice they hear is, give him some formula. He is hungry. It will do nothing wrong. These are the beliefs which are embedded for decades that artificial feeding is the standard and safe. But does it hold true with the current scientific evidence? That's what we are going to learn about it. So, what exactly happens and what is lost when formula replaces human milk? We know that the human milk has a unique composition. It contains almost more than 200 human milk oligosaccharides, secretory IgA and lactoferrins, and the macrophages and the stem cells. So, whenever the baby is formula fed, so there is no living maternal immune cells, and they have a very different immunologic and bioactive profile than the human milk. So, whenever a baby is fed even once, it whole gut microbiome changes. So, and the most important thing is the breast milk is unique for each infant, but the formula is standardized. And we have a population level evidence associated with breastfeeding that breastfeeding lowers gastrointestinal and respiratory morbidity. And in in case there is early unnecessary supplementation, which reduces the breast stimulation and in turn causes lower milk production. So, the risk with the gastrointestinal and risk for the preterm. So, first is gut microbiome. As we know that the breast milk infants has the good bacteria and the good pathogens, but the formula fed infants formula fed infants has the different and the pathogenic bacteria. It mainly colonizes Enterobacteriaceae and the bacillus. So even once the baby has been fed, the whole gut microbiome changes, which in turn leads to the different kind of diseases like recurrent diarrhea and the gas and the bloating in the formula fed infants. The second most in the problem is infection, and the infection can occur in two ways. The first one is compared with the breastfeeding formula feed, infants lack the different protecting antibodies and other protective factors, unlike the breast milk fed infants. And if there is a error in the preparation, that also has a direct pathway for the infection. And the third one is for the preterm and the very low birth weight infants. We have seen that whom human milk is preferred because it lowers the chances of NEC, which is more in cases of formula feed. So now the most important part is not about only the formula feed, but what about its preparation. Preparation errors also can convert nutrition into hazard. So powdered infant formula is not as sterile. Incorrect concentration, contaminated equipments, and unsafe water strongly delay or reuse of leftover can cause hazards. So, what if the formula feed is too concentrated? It causes excess renal acute load and inadequate pre-water. which is potential hazard for the young infant's kidney. And the formula feeds are too expensive. For some mother can over dilute it, which in turn causes inadequate energy and nutrients to the infant. And the most important, the contamination and the storage. Powdered hand surface bottles and warm prepared feeds are the call are the w- they are the most important for the pathogens to colonize. The most important part is the dangers of infant formula, which none of the formula companies tell us. And it is not only associated with the child, even it is associated with the mother. This is most important for all the mothers to know if the mother is not breastfeeding, what and all problems can happen. So for the child, it can lead to the chronic diseases like asthma, allergies, ear infections, high blood pressure, and respiratory infections, and the disease goes on. And for the mother, they can lead to the diabetes, either gestational diabetes or an over diabetes, and the mother can have a breast cancers, ovarian cancers, and the cardiovascular diseases, and even it reduces the spacing. So the second thing is about the bottle feeding. The bottle feeding, we have often seen telling parents that mother, no ma'am, no doctor, we are giving breast milk only, but in the bottle. So it is important to know that there is not important what it contains. The bottle related problems are also there. So the main concerns are contamination, non-responsive feeding, and prolonged exposure. So the first one is contamination. The bottle teats, rings, and the walls are surface. They retain milk and residues, and inadequate cleaning or sanitizing increases the chances of microbial risk, which in turn lead to the infections. And the flow driven feeding. The breastfeeding allows babies to feed on and its own pace, but a fast flow bottle or forcing a baby to finish the bottle can make them drink more, and they are overfed. And the most important part of the bottle feeding is about the breastfeeding interference. That is, some infants develops a preference for bottle feed. After that, it becomes very difficult and it complicates with the breastfeeding. So, oral health harms and exposure dependent. These are mainly dependent on the amount and the persistent exposure to the bottle feeding, which can lead to the early childhood caries due to the prolonged contact and the bottle to sleep habits. And the prolonged artificial sucking pattern may influence malocclusion. And for this, the most important part is duration and the persistence. So the third topic is about the nipple shield. So, the main concern with the nipple shield is about the milk transfer. The milk transfer, the poorly filled nipple shield or a shallow latch or altered mechanics may reduce the transfer, and it requires the longer feeds and inadequate intake or breast drainage. Because of this, there will be a fatigue in the mother as well as the baby. And there can be a supply impact because of the interference which happens between the mother and the baby. So, if effective milk removal falls, breast stimulation falls, persistent inadequate removal can reduce supply. The most important part is about the monitoring. We have to track the swallowing output and the weight. So, associated nipple shield, maternal harms and hygiene and dependence remains a main concern. The first one is about the pain and trauma. The wrong size nipple shields, the excessive friction or the compression can cause nipple pain, edema, and tissue trauma. The second is about the poor drainage. That is, ineffective emptying may contribute to engorgement, blocked ducts, or mastitis. And the third is about the hygiene issue. Mainly, the nipple sheets are made up of an artificial silicone, so there can be a microbial growth which is present. The fourth one is about the dependence. That is, some infant become reluctant to latch without the shield, that prolonging divide dependence. And the most important part, the root causes marks. That is why baby is not latching. The first important part, which is is it because of the pain or the tongue function, positioning, or a low supply, can remain untreated while the shield is temporarily works. So, the pacifiers, the most commonly used, we have the pacifiers which is used to calm the infants. So the harm occurs when sucking replaces feeding or if it persists too long. So the first one is about the missed feeding cues. If it is used to postpone the feeds, breast stimulation and milk removal may decrease during lactational stabilization. That it may decrease the breast milk production. Second one is about the long-term pacifier use, which is associated with the decrease, which is associated with recurrent infection, ear infection, and the dental effects. That is, persistent non-nutritive sucking can contribute to the malocclusion. So now, and the still the main concern remained about hygiene, oral colonization, and the safety about the pacifiers. As it is artificial, it can again contaminate from the hand surfaces, inadequate cleaning, or because of that, the oral microbial candida colonization has been reported. So, the most important part about the pacifier is about the counseling should distinguish soothing, safe sleep use from using a pacifier to just suppress the hunger cues. So now about the breast pump, which is commonly used as we have a working mothers. So now the thing which is related to the breast pump is about the maternal tissue injury and supply dysregulation. So the wrong flange fit. If the breast pump too small, so it leads to the rubbing and compression. If it is too large, it leads to the excessive areolar tissue drawn into the tunnel. Both can cause pain and edema. If there is excessive suction and the high vacuum does not equally better milk remover, it can cause pain, bruising, fissures, and nipple trauma. And the third one is about the oversupply. Unnecessary frequent pumping causes hyperlactation, which can cause engorgement and causes recurrent inflammation. So now again about the contamination. It can contaminate the expressed milk into an infection risk. So milk residues on the breast pump supports bacterial growth, and it is more often seen in the premature, less than 2 months old and immunocompromised infants. So the sixth topic is about the human milk fortifiers. So we cannot say human milk fortifiers is inherently harmful. For preterm VLBW infants, it can be clinically necessary. But this section focuses on adverse effect and preventable risk of fortification. So WHO guidelines on initiation of human milk fortifier. WHO doesn't recommend routinely for all preterm and LBW infants. It may be considered in very preterm, that is less than 32 weeks, or a VLBW infant that is less than 1500 gram. And it should be always fed with mother's own milk or a donor human milk. And first, there should be stabilization of the internal feeds. That is commonly the human milk fortifiers are added when the feeds are reached more than 100 ml per kg per day. And timing and duration should be individualized based on the clinical judgment. So, why do we need fortifiers? So, the preterm premature babies have a higher target of protein, calorie, and the other minerals, which has been seen that it is not clearly achieved with the mature human milk, even if we take a 150 ml per kg per day. So, to meet this demand, we have a human milk fortifiers. So, what are the protocols for fortification? So, first is early eternal feeds stabilization. We have to initiate a early eternal feeds with mother milk or a donor human milk at about 15 to 24 ml per kg per day. This stimulate gut development, and then we have to gradually increase it to 20 to 30 ml per kg per day, and we have to stepwise add the fortification once it reaches to around 100 ml per kg per day. And we have to monitor and see about the fortification. So why the benefit risk balance is different in case of HMF? So some babies can have feeding intolerance, that some infants may develop increased gastrial residuals, distension, or stool changes. So we have to clearly evaluate the whole scenario. The second is about the osmolality and the mixing. Adding fortifiers and other additives raises osmolarity, which in turn causes the load on the infant. So that can cause increased feeding burden. And the third one, the most important, is about the contamination. We have seen so many contamination because as it is a powdered product and not sterile, so we have to use the very much sterile techniques even in the NICU or with the CDC. So now, what are the clinical adverse effects to monitor? Fortification, first of all, the fortification should be individualized to gestation, weight, growth trajectory, biochemical state, stress, and the feeding tolerance. So first, if there are incorrect concentration of the fortification, that will lead to the excessive nutrient mineral load, or if there is an inadequate fortification, that also will lead to the adverse effect on the infant growth. The second one is electrolyte mineral disturbance can occur if fortification is not matched to the clinical or laboratory monitoring. And the third one, if the fortifiers are of bovine milk derived, that can cause an intolerance or the allergy. That is not uncommon but clinically relevant when suspected. Now, the fortification does not replace the priority of mother's own milk or a donor human milk is preferred over formula for many very preterm infants when maternal milk is insufficient. The most important part here is any suspected NEC, sepsis, or significant feeding intolerance requires clinical evaluation, not simply attributing symptoms to the HMF. So, the 6 topics and the 1 clinical principle is about that the breastfeeding remains the best for the infants. These are my references. Thank you so much. Thank you, Raksha ma'am. Can you take over?
Thank you, Dr. Smita. Yes, thank you for that wonderful speech. So now we will be moving over to a small talk on IMS because I want to hear from our panelists, then we speaking ourselves. I'll be just talking for 5 to 10 minutes on IMS Act, then we will move on to panel discussion. So I'll be sharing my PPTs. Is it visible?
Yes.
Yes.
Yes, okay.
I just wanted to add, all my
Yes.
colleagues have come from different medical colleges, and they say nobody taught them the way that was happening in my department now. And I've involved only youngsters. We are sick and tired of listening to the seniors with the same old slogan. So I'm so proud, and the way Smita did. Over to you, Raksha. Just a small interruption.
Yes, ma'am. Thank you, Asha ma'am. She is my teacher from my BMC days, and now I work with her. I am thankful to you, ma'am, for the opportunity. So I'll be just talking about giving a brief on IMS Act 1992, which was revised again in 2003 and 2006 again, where Food Safety Standard Act also was added to it. So when we look at a mother and a baby, it's like a sanctuary, right? Like we have to save them at all costs. So they are like prone for environmental influences. They are at a very tender stage. So that's why the law comes into picture. So mother and baby, they form a biological unit, which is inseparable. But in today's age of so much of information, from everywhere, from TV, from internet, they keep getting information that by using some formula or by using some infant food, baby grows better. So it's our responsibility as well as the responsibility of the IMS Act as society as a whole to protect them at all costs. So what exactly is infant milk substitute? So any food marketed as partial or total replacement for mother's milk for infants up to the age of 2 years is considered as infant milk substitute. Infant food is any food marketed as complement to mother's milk to meet growing nutritional needs after 6 months up to 2 years of age. Total is any media which is used to give milk to the baby which has teats. So just go through the slide and mentally cast your vote. Why I have put this? I'm 100% sure all the pediatrician or any other health care professional will get 10 out of 10 marks when quiz is given like this, because we have the knowledge what is right. But when we are implementing it, that is when the problem arises. Why this there is a gap between this knowledge and implementation that we will just go through. So the most common cause when we see in a hospital setting of starting formula will be perceived insufficiency. So either mother comes thinking that milk is not sufficient, or the family members, grandparents, grandmother, they keep telling the mother, your milk is not sufficient. That's the reason baby is crying excessively. That's the first concern with which they come to the hospital. Here, our main goal, when a baby, let's assume a 15-day-old baby comes to our OPD with such concerns, our first and foremost goal should be to assess for the weight gain, assess for the urine output, check for the feeding, what is going wrong. And most of the time, it's the problem with attachment, feeding techniques. And if we correct those, and if we reassure the mother and parents and have a regular follow, most of the problems can be solved. But usually what happens when there is a busy pediatrician who is seeing multiple babies at a time, so the more easier thing is to write formula. So or sometimes it's not just that, most of the pediatricians they also tend to think that milk is not sufficient. So that's why where this knowledge and implementation gap is coming. So that's why this IMS Act is very, very important. So we have an IMS Act. These are the 4 important pillars. There are around 26 sections, and these are few important sections which I will be talking about. First is it talks about absolute ban on promotion. So then comes healthcare system firewall, which includes this section, then educational labeling and quality standards. So coming to the total promotional ban, anything, it may be through TV, it may be through internet, it may be through posters or newspaper, or giving gifts to the pregnant mother, everything is banned. Even the person from a pharma company approaching parent mothers directly or any family member directly is prohibited. So second thing, our healthcare, it should act as a firewall. It shouldn't act as a loophole for pharma companies or formula companies to develop. We act as a firewall where we protect breastfeeding. So no posters in OPDs, no educational material regarding particular brand of formula to the mother. Whatever feeding difficulty happens should be corrected in one-to-one discussion with the mother and the family. And this is one which is happening very frequently, sponsorships. Sponsorship for seminars, meeting, conferences, which is again is prohibited, and we have to take care of that. Then coming to educational materials, usually it is allowed for the companies to give educational materials to doctors. Doctor having knowledge of different brands is equally important, but that educational material should contain exact what is needed, like breastfeeding is best for the baby, what is the content of that formula, what are the things, like it should never say it is superior to the breast milk, it is superior to breastfeeding or equal to breastfeeding. Those things shouldn't be talked about in educational material checklist. Then comes labeling. This is for the companies. It should never be written something like humanized, maternalized, never put a photo of a baby or a mother or both of them together. So also mention in detail about the contents, expiry date, what are all the side effects which can happen. So everything should be maintained here. Then there is a Food Safety and Standard Act, which again food safety standard, the safety officer can come, they can come and inspect the formulas, and they have authority over it. So only one exemption for donation or giving subsidized rate is to the orphanages. Again, it should be used as a benefit rather than some loophole through which they subsidize and give formula to the parents. Okay, so what is right, what is wrong? We'll just skip that. So there is penalty for everything. If someone is found to have some formula which is substandard, quality is not up to mark, so food safety officer or any gazetted officer from government, they can confiscate. So, and there can be, according to law, according to court, they can be punished. So even when it is a company which is not maintaining the standard, the managers, the person who takes the decision, as well as the company is liable. So what is the penalties? So why we talk about penalties is it sufficient or there should be more? That's what we should be talking about. Initial offenses like promoting the brand, giving gifts. So they have penalty of imprisonment up to 3 years or fine of 5,000 or both of them. So then offenses relating to quality. So then again imprisonment up to 6 months. It can go up to 3 years and 2,000 penalty. So again, government itself can take rule making into its hands and it can change the rules so that it can protect breastfeeding. So one of the loophole of this IMS Act is, as a doctor, if I find someone promoting a formula brand, can I go directly to the court? No. Usually it has to go through food safety officer or state government or voluntary organization. Then only it is cognizable. So, and as well as it's a bailable offense, so the person who has promoted can always fight. There are few loopholes and protection are still there. So these are like there is a power of seizure, penalties, and legal cases. But at the end of the day, is this working? I won't say it's like a completely everyone who is promoting formula is imprisoned or put a fine. So at the end of the day, it is our responsibility as pediatrician, lactation consultant, nurses to protect the breastfeeding. So protect our space. That means wherever we are practicing, see to it that we do exclusive breastfeeding. Reject inducement. This shows our personality. So reject inducement and educate with all your will. So it's our conscience versus formula brands, right? So we are the wall of protection, even though there is IMS shield. At the end of the day, we as pediatrician, we need to protect breastfeeding. Thank you. Thank you all for listening. We'll just move on to the panel discussion. Yeah, we really want to hear from our seniors. So I will be just sharing the questions, or shall I'll just share them. First question to Dr. Sandhya Satish Karse ma'am. One second, ma'am. Sandhya ma'am, NFH6 shows that despite improvements in early initiation of breastfeeding and institutional deliveries and exclusive breastfeeding, like exclusive breastfeeding has fallen from 63% to 55.8%. What do you think is driving this decline, and what are the 3 measures, interventions we can do to help India improve our exclusive breastfeeding rate? Over to Dr. Sandhya ma'am.
Sandhya, are you
Sandhya
there?
ma'am? Sandhya ma'am,
He was there all the time. Sandhya, unmute
She's
yourself.
getting her
Yeah,
slides.
Sandhya, unmute.
ma'am,
Madam
it's
is
muted.
there. She has to unmute.
Yeah, we can see you unmuted now.
Okay.
You're
Am I
you're
audible
audible
now?
now. Yeah, yes, madam, you're audible.
Yeah. Thank you very much. First of all, I will thank IAP and all the other associates who have invited me for this particular panel discussion. It's a great honor for me to be with all of you, all stalwarts. My pranams to Dr. R.K. Anand sir, who really motivated me for this breastfeeding part, which I am doing so far. I learned all the intricacies with sir when I was a senior resident at Just Look Hospital. Now, coming to my question, what I want to say here is that very important aspect is the strengthening of breastfeeding practices, which is actually not being practiced to that extent in most of the institution and the delivery places. Rather than going for many of the things, we have to think about certain doables, which is possible in each and every place where there is a delivery and where you are caring for a mother and child. Like, for example, we always say that support is needed, mother requires lot of support for breastfeeding. But I just want to say that to chop an onion, does the lady require any support? The same way, if we can empower her right from the beginning of her conception, that breastfeeding is best, nothing else is better than breastfeeding. She must exclusively breastfeed her babies, telling her all the advantages and making her empowered to take the decision that she will feed her baby on the breast. When a mother becomes that much empowered, she will not require anybody else's advice also. If she understands that this is something which is very good. This can happen. It is a very simple thing which we can do right from the antenatal period. There has to be the feeding counseling in each and every area where there is an antenatal clinic, the structured antenatal clinic. Even BFHI tells us that you counsel the mother right from the antenatal, prepare her for breastfeeding, make her confident enough to breastfeed. Then she will not go for all these misconceptions and promotions and all those things. Secondly, the support has to come rather than coming to the from the family and from the husband and from all other things. It is the support at the hospital. Each and every one where there is a pediatric and OBGY unit where there is a delivery taking place, each and everyone has to give support. They should be enriched with all the advantages of the breastfeeding. They should be trained for counseling the lady for the breastfeeding. Like in my hospital, right from the registration counter, when the mother is coming, from there the promotion for breastfeeding starts. Everybody asks her, which is the number of pregnancy? Have she breastfed her previous baby? What is her objective? Does she know about breastfeeding? Like that, if everybody speaks the same tune, the same way, then definitely there will not be any problem at all. Main is that most of the communication part is not there, and undergraduates and the postgraduates, where there is a medical college, mushrooming medical colleges are there 840 medical colleges in the country. Out of that, how many medical colleges have got the human milk bank? There is a breastfeeding strengthening practices there in the medical college. Who has monitored that? The National Medical Commission, when they say that this is required, that is required, these are the requisition for post-graduation, they give up, they bombard us with the list of requisition. Where else it is mentioned that this is something compulsory, and for starting a postgraduate course in OBGY or a pediatric, you should have a baby-friendly hospital, breastfeeding healthy policy, or you should have a human milk bank. Now, these three things, wherever they are, automatically the breastfeeding can progress. There will not be any problem at all if they are there. Wherever there is a sensitization, wherever there is an awareness, when it is a baby-friendly hospital, when it is a baby breastfeeding-friendly supportive hospital if it is there, and when there is a human milk bank in that particular hospital, 100% most of the time the breastfeeding will not be compromised. So these are certain simple doable things which is very easily it can be done. It's not that it is not possible. Making a child-friendly labor room. The labor room atmosphere in many of the government setup, it is so horrible. It's horrendous. It's thus not possible to initiate the breastfeeding. And once you are not early initiating the breastfeeding, entire things goes wrong. Early initiation and then sustainability of the breastfeeding, that is something which is very, very important. It's not just early initiation. So for early initiation and sustainability, the mother has to be totally confident. She has to be sensitized. She has to be motivated. And that has to come right from her antenatal period. If that is done, I don't think there will be any problem in having this particular breastfeeding rates rise. That is not being done. Doable, simple doables are not done. In the labor room, if you can provide a special assistant, a lactation consultant or counselor if possible, or at least a dedicated nurse. If you can keep a dedicated nurse to start early initiation of the breastfeeding, you tell the sister on duty, you tell the doctor on duty that put the time of the delivery and put the time of early initiation of the breastfeeding, then see to the sustainability of the breastfeeding, catch hold of your ASHA worker, your ANM, your all other worker, community support, visit the community, do the mobile tracking and see to it that the sustainability of the breastfeeding. And for this, the interns, the students, the postgraduates, everybody should be trained. And for that, there has to be some compulsion. We have 253 competencies in the undergraduate curriculum for the MBBS pediatrics as per the new CBME curriculum. Out of that, there are only 8 competencies for breastfeeding and 5 for complementary feeding. Now, that is also certification is not there. That means what weightage we are giving to this particular chapter in pediatrics. So the students who are getting the admission, they right from the beginning are interested in endocrinology, cardiology and all other things. And breastfeeding is something which is totally a negligent, something very simple thing, which is not to be told at all. That is the way the things are going on. And unless and until there is a practitioner, there is a consultant who himself is a passionate about breastfeeding, most of the time these things are not practiced. There, whomever we are creating, the future doctors whom we are making, we are not sensitizing them as such. Unless and until there is some compulsion, the things will not work. So if that things go on, and if there is some curriculum part, there is some weightage is more is given, giving some incentives to the public also. In many of the other countries, in Singapore, they reduce the tax when people work for social cause. Now, if somebody is promoting in our country also, if we can bring this particular that whoever is exclusively breastfed babies, their mothers, sustainability of breastfeeding if maintained, and they have not given any formula fit, some incentive in tax reduction you give. That can strengthen the breastfeeding practices. That can immediately dramatically raise the semi-urban population, which usually goes by all this promotion. Let me tell you, the rural woman, that ground reality, the staff who are coming to our government setup, they are not lured by any of these promotions as such. It is the healthcare provider who is prescribing the formula fit to them. Nobody tells that I want this. This is somebody who prescribes to them. So if that we can stop. You spoke very well about the IMS Act, but what is the conviction rate for those who have violated the Act? It's not more than 1% also. In 2024-25 and 25-26, not even a single criminal conviction is there of IMS Act. Now, what about this Act and how we are going to follow? So these are doable things which is possible, feasible, available, acceptable. If we can do it, then there will not be any problem in strengthening the breastfeeding practices. Make the mother self-confident, let her understand, let her take the decision, and let her be the first to decide that I want to feed my baby on the breast. She doesn't require that much of the support. This is my very frank view. I have been doing this since a long time and I'm quite successful. I am right now working in a very private medical college. It was a corporate medical college, 37 years old, but every formula was prescribed so far since I joined, 2 years. The entire hospital has become breastfeeding friendly, and we are starting a human milk bank on 10th of September 2026. So we have improved our statistics. Our patients are now breastfed right in the labor room, right in the OT, LSCS. Immediate breastfeeding is done, the time is put, and everything is in place. So these are certain things which are doable if everybody wills and if everybody can do it, then definitely there should not be any problem. I'm very happy that all the people from different stakeholders, they have come together in one single platform where we all will speak the same. If that is followed, I think this statistics will 100% improve. And this is something which is very, very important. Thanks to Neelam Mohan Madam for this wonderful idea of bringing all stakeholders together, NNF, IAP, FOXY, everybody together, so that we all will work together, we all will promote. Wherever there is a lactating mother, we will try to help her, make her self-sufficient so that she herself can take the decision.
Correct, ma'am. Thank you for that answer. As you said, at the end of the day, it's we doctors, our knowledge, and how much motivated we are. That's what takes forward breastfeeding, I think. So, yeah, we will also try to work on that. And there's a strong system of all us healthcare professionals to start early breastfeeding and sustain the breastfeeding. Thank you, ma'am. So we will move on to question to Dr. Mangala ma'am, and I'll come back to you again, ma'am. Question to Dr. Mangalavani ma'am from FOXY. So, ma'am, mothers are often exposed to commercial promotion of infant feeding products during pregnancy, the immediate postpartum period. How can obstetrician effectively counsel families, counter misinformation, and ensure that infant milk substitutes are recommended, or only when needed, or not recommended? Like usually, how do we protect mothers against formula milk as an obstetrician, ma'am? Over to you.
Yeah, thank you, Raksha. First of all, I feel very honored and humbled to be here on this very prestigious forum with IAP, with the FOXY and neonatology and the nursing department. And I think, Raksha, this is a very, very important issue that you have asked me about this early initiation of the breastfeeding. Dr. Kharse madam has done my half of the part. And as Dr. Dadich said even earlier, that NFHS 6 data says that there is some improvement in the early initiation of the breastfeeding. So me as an obstetrician, I think we have a very, very, very important role. We are looking after the mother for 9 months during the pregnancy. We are the first one who are in contact with the baby, So this mother, we are seeing her for 9 months. So she has more trust in us. So she listens to us, So first thing is the preparation of that mother is so important. So arranging the antenatal classes only we can do because the mother is in our care that time. So beginning of the 7th month, I think the separate class should be there, and at least it should go for 1 to 2 hours. And then we can give her the all information starting from the benefits of the breastfeeding. And we don't tell her only the benefits of the baby. We have to tell her what are the benefits to her, because she will ask कि मैं जो इतना कष्ट करूंगी मुझे क्या मिलने वाला है ना. So the benefits, and mainly the long term benefits, the protection from cancer of the breast and the protection from metabolic diseases, the protection from obesity, from heart disease, from blood pressure. All this we have to explain to her, from diabetes, which has become very, very high these days. And then even in every visit she comes to us, we can do some sensitization, about the breastfeeding. Just tell few sentences when we are doing the rest of the checkup. So this is the antenatal period. Now at the time of delivery, what we say, you initiate the breastfeeding within 1 hour. So it seems very easy, the baby is born and the baby is put to the breast. And why it is not happening when it is easy? Nearly two babies out of five, they are not getting initiation. And it is more so in the private sector. And there are so lot of barriers. So usually what happens, the baby is born and then it goes to the, once the baby is given to the pediatrician, then the obstetrician is no more concerned with the baby. And I think that is not on, So then the baby is in the warmer, then the pediatrician, what it does the suction. Like, this baby is so cozy, 9 months in the mother's tummy. And now we start insulting that baby. If we go to the dentist and, when the dentist puts the suction and how we put, and the babies, that mucosa is so fragile and so delicate, sometimes get bruises also. And then that baby refuses anything to go in the mouth. And that is how even there can be delay in from baby's side, initiation. And then we weigh the baby, we give the vitamin K injection. There are a lot of practices I have seen, giving oil massage, giving bath to the baby, and then putting the clothes. And then the mother has to have the episiotomy sutured up, cleaning up. And there is always shortage of the stuff. They have to complete, all the paperwork and everything. So meantime, the baby goes aram say to the room or the ward, wherever the mother was. And then somebody gives the top feed by the time the mother is, in the still recovery, and then transferred to the room. So this is why all the delay. And once the baby is given top feed, baby is full and the baby refuses. And then the baby's imprinting started happening. How my milk are given to me, something ready-made put into the mouth. And then there may be delay in success of the breastfeeding. So we have to change all those practices. So we all have heard about the breast crawl, that as soon as we put the baby on the mother's tummy, the baby actually knows how to reach up to the breast. So those techniques, and I think the health professionals, the training is so important in this case. Every health professional who contacts with the mother and the baby diet, they should have a regular training. And what does that training? That is the knowledge about the breastfeeding, hands on the skill, and the counseling skills. All those three components are very, very important, that every health professional should know. And this is how we can increase, the initiation. Even going to the ward, when the mother is in the early postpartum period, whatever happens in the hospital, that continues at home. So it is very important that we do in a right way. And as the Sandhya madam already said, that the training and the BFHI certification is so important. Now every time we do round, just 2 minutes we can check, has the baby passed urine in 24 hours, how many times the baby has passed stool. That is also very important in the beginning, the passing of the stool. And of course, watching the baby's weight on the day 1, then day 3, day 5 at discharge, and then again day 10 and then 14. Then only we know whether baby is getting enough. Just telling mother you just feed your baby is not enough. And that is how then we come into the problem. And then the mother is already bombarded with the family, with the formula companies, and the mother gets succumbed, to this formula feeding. So it is very, very important. The seniors, knowing about the breastfeeding, then they can change the policies of the hospital. and they can guide even the juniors if something is going wrong. Because when I am doing the round, me as a obstetrician, and I am as a specialized in breastfeeding medicine, I know this sometimes the untrained nurses, how wrongly they put the baby to the into the latching or into the position, and then the breastfeeding doesn't happen. So, and the small things, if we correct, just give some time, I think the journey is smooth afterwards. So that is why obstetricians, I feel, has a very important role. Recently, I conduct the conference every year in Pune. This time we had 296 health professionals attended the conference. And it was amazing to see now there is a more interest amongst the health professionals and more interest in the obstetricians, and I'm very happy about it that the things are changing slowly, but yes, we are in a positive direction. Thank you.
Thank you, ma'am. And I was going through your CV, and I'm very happy that you, being a gynecologist, you are a lactation consultant, that too one of the senior practicing IB-CLC in India. Yes, we are very happy with that, ma'am, and thank you for your answer. So moving on to next question, Dr. Amit sir, it is to Dr. Amit Upadhyaya sir. Sir, how can healthcare professionals... Hello? Hello, sir, you're there, no, sir? Huh? Yeah. So the question is, sir, how can healthcare professionals and academic institutions balance the need for industry-supported medical education while ensuring full compliance with the IMS Act and avoiding conflict of interest, sir?
Unmute.
Sir, I think you are muted.
Please unmute yourself, sir.
अरे unmute करो, मेरे समझ नहीं हो रहा है.
Raksha, please call sir and tell him to unmute, no? That looks better.
Okay, sir. Okay.
Amit, you're not audible. Amit, they are waiting for you. Unmute. Dr. Amit Upadhyay.
I'm calling him, ma'am.
While he joins, I will just say, Sandhya ma'am, to think and revert. I sent a mail to Pan India saying that I want to spend 2-3 crores to branches who want to start milk bank. Not a single branch applied, ma'am. 3 crores I had sent a mail. Now, what do you want me to do? Just, I want you to know. You're talking, it is not feasible in a corporate. It has to be in a region. Suppose in a place, in an area, in a branch. So we said that you put in some money, we put in some money, sustainability. This is the money I'll put, and I pass it in the GBM in January with my innovative ideas. But nothing is being translated because the resistance, the asking. So I just want you all to know what I'm also feeling your pulse.
Is Dr.
What is he saying?
Manju Vatsa ma'am is present? Can I just...
But Amit is walking. I can see him walk. Why can't he
Please
just...
select, he is trying to unmute, ma'am. I'll just go ahead
he
with the
could
next.
unmute.
Yes, I am here. I am here.
Yes, sir.
He's
Yes.
unmuted now.
I'm here.
So question you want me to repeat, sir? You heard the question?
Yes, sir. Yes, madam.
Shall I repeat? Okay, sir.
Yes, madam. Yes, ma'am.
Okay, sir. So, sir, how can healthcare professionals and academic institutions balance the need for industry-supported medical education while ensuring full compliance with the IMS Act and avoid the conflict of interest?
Yes, that is very important to do so because in medical education, if we involve IMS Act companies, then not only the current doctors are harmed, but also the students get an impression and message that it is okay to liaison with IMS Act companies, and that is the worst thing. If from MD level you start interacting with IMS Act companies, then all your life you would be the same. So a person in private, if he does liaison with IMS Act company, he's only one individual who is getting involved with that. But if a college just does that, then if there are 25 postgraduate students, then it is one person plus 25 PGs who get involved with the IMS Act companies. And they start thinking this is normal because it's part of their teaching curriculum that IMS Act comes into. So that is why the onus is, on the medical education or the departments, the pediatrics departments and neonatology, that they should be strict, censure on use of IMS Act companies in the departments, be it in the form of library, be it in form of travel grants, and lectures should start from undergraduate levels so that UG students know that, PG students know that, and many a times we see there is many right there in the degree PG diploma nutrition Boston, and 100% of such degrees are IMS Act sponsored. So that is something which is almost acceptance of a crime which has been done. So that we should always say that these PG diplomas in nutrition and all, we know that there are certain companies who get you these degrees, and so they are unacceptable. So all the PGs, all the doctors should be made educated about this. Any educational activity involving infant and young child nutrition should undergo conflict of interest review, and full disclosure of funding sources should be done. There are many conferences still going on in which pharma companies from IMS Act, they sponsor candidates. And so that also should stop. So institutions should establish clear policies prohibiting sponsorship, gift, hospitality, promotional support, manufacture of infant milk substitutes, and they should be taught about IMS Act in detail. That's what I have to say on this question.
Yes, sir. Thank you, sir. Thank you. I just wanted to know, Dr. Manju, what's up, ma'am? Is she there? She was from INC. She is the panelist from INC. Okay. If she's not there, I'll go ahead with my question for Sandhya, ma'am. Again. So, ma'am, in what clinical situation is infant formula genuinely indicated? And how can healthcare professional ensure that its use does not inadvertently undermine the breastfeeding? My question for Sandhya, ma'am.
You have asked such a question that I don't agree at all, and genuine indication and all, I don't believe in any of these formula feeds as such. Okay. So before starting only, it's very important to make sure that the mother is comfortable with the breastfeeding. There is a proper latching, positioning, all the need for the breastfeeding, whether she can do it, fully encouragement to her for breastfeeding, once again counseling and everything, so that all smaller indications, because the moment you said that in these conditions, because mother is unable to feed the baby, if that is one condition, if I say, then each and everybody will start telling about all formula feeds only, because many times mother is unable, mother, it is very difficult and so many things. So that is why it's very important to ensure that all practical things have been done and the mother is really not having enough of milk at all, or there is no secretions. Again, reinduction of lactation is there. Lactation can be reinduced also. Many things are there by which you can start the breastfeeding and give. Wherever there is a human milk bank nearby, you can definitely go, because next best option to mother's own milk. Mom is the best, it's warm. And then second is milk from the human milk bank or donated human milk. If these two options are still not available, then one or two very rare indications like galactosemia and all those things, that is something where we can. But I sincerely feel that unnecessarily this formula as such should never ever. First strengthen the breastfeeding practice, see to it mother most of the time can relactate, mother can successfully, she can feed the baby. There is always the problem of latching, score, positioning. Asha madam has been doing all this difficult situations, cleft lip, cleft palate, everywhere. There is possible, if you are passionate to induce and start the breastfeeding. I don't think the formula feed is required somewhere. I will never ever try for that. And because fortunately I have been working wherever I have started the human milk bank. So I never had this particular opportunity to prescribe all these things. But you have to ensure that there is really a need, a medical condition proper. And sometimes I feel that if the mother is not breastfeeding, then we have to take a consent also. In the meanwhile, one of them had sued and they had filed the public interest litigation that those hospitals who are prescribing the formula feed should take the consent that we are giving this, but this has got these harms. You explained so nicely, or the harmful effects of formula feeds. So that has to be mentioned when you want to really give a baby a formula feed.
Yeah, ma'am. Thank you for that answer. Yes, we kept that question mainly because we wanted participants to know there is no genuine indication for starting on formula. Yes, thank you for that answer, ma'am. Yes. Moving on to Dr. Manglavani, ma'am. With increasing rates of cesarean deliveries, what practical strategies can help mothers establish breastfeeding successfully despite post-operative pain and delayed mobility?
Yeah, again, my baby is saying hello to everybody because now we are going to do little demonstration. So yes, uh, as a obstetrician, when I have done many cesarean sections, and we have demonstrated that more than 98% of the cases, we can successfully initiate the breastfeeding within 1 hour as WHO recommendation, and we can successfully continue the breastfeeding exclusively for 6 months. Now, I also I'm a national BFHI assessor, and Dr. Sandhya Khadse madam is the witness for that. Our team, we have gone to her medical college in Nagpur, and we have demonstrated in operation theater how we can initiate the breastfeeding. And Sandhya madam was so motivated and she's so meticulous. Now every college she goes, now she has put that practice, even after cesarean section initiation of breastfeeding. So what I mean, it is not only the theoretical talking, practically it can happen. And that is why the demonstration in every OT is very, very important, because just like that we say, then there are so many obstacles. And with even the anesthetists, everybody has to be baby friendly. So when the cesarean section, just when the baby is out, okay, let the pediatrician take the baby for few minutes just to quick little checkup and drying up the baby. So now that baby has to come to one person who should be responsible for initiation of the breastfeeding for that baby. So, and then because the cesarean and there is a screen in between, so now there is no space like normally breastfeeding like that. So what we do, above the shoulder there is a place, but it is next to anesthetist. That is why anesthetist has to know about that. And I think some speaker also said earlier, even the anesthetist has to be included for the training, which is 100% true. So what we do, we don't wrap up the baby or we don't put the clothes to the baby. Again, positioning, when we are teaching, sometimes it takes 4 hours even to teach the baby's latch and the positioning. So we again give support to the baby's neck. This is the weakest part. We never hold on the head or we never press the head of the baby, you know. So because the baby's head has to be extended while feeding. Like when I am drinking the water, I don't drink like that. My head is extended and I drink like that. So it is comfortable for the baby. And so on over the shoulder, the baby comes like that and the helper holds the baby, like that. And then the baby can be latched. Again, it has to be, exactly in line with the breast. Now, if we hold the baby like that and try to give, it is not possible. Again, that latch is going to be superficial and the baby will not start sucking. So we have to make sure that we support the baby, because there is can be lot of vernix and baby can be slippery. So one thin, the green cloth we can have, so that the baby doesn't slip. Make sure baby doesn't fall down. Very, very important. And then we give the some hospitals, they also give like that, but I find this way it's much, much easier. And the breastfeeding has to be complete. Now the baby doesn't start sucking immediately. There are 9 phases that we described after the baby is born. So let the baby go through that phases. So once the baby is ready, usually within 10 minutes baby starts sucking. Some babies start immediately beautifully. So let the baby start and let the baby complete the feeding. So by that time the suturing is also over, and then we give the second feeding when the mother is in the recovery. And of course the important parts again comes when the mother goes to the ward. Now there is a family waiting, and there are lot of myths कि mother hasn't eaten anything, उसको दूध कैसे आएगा. Then she has taken lot of medication, so probably it is not right to breastfeed. Again, mother is not mobile. Normally the cesarean is done under spinal, so the baby is fully, mother is fully awake, and the spinal anesthesia wears off in 2 to 3 hours. So then the mother can turn and the breastfeed. So even if initially she is difficult, finding to turn, then we can put the pillows on the side, and so in the same level we can put the baby up and feed. We have to show this all to the relatives also, so that they can frequently, what we say in the beginning, first 10 days we have to breastfeed the baby frequently. So 2 hourly even, so 10 to 12 times in first 10 to 15 days, till the breastfeeding is established, until the baby's weight has come back to the birth weight. And then once the baby's mother can turn, then mother can turn on one side, baby can turn on the other side. And the second day all our section patients are walking. So normally I make her sit on the chair, put some pillows, and then show the cross cradle position. I always find the cross cradle position is much better and more successful in all the mothers in the beginning, rather than the cradle hold, because the support at the baby's neck is very, very important. So that is how, even if, and the pain management is again important. And what is my experience, when we put the baby to the breast, actually even the mother feels less pain from cesarean, because her attention is diverted to the baby, and there is a lot of oxytocin in her body, so it should not be issue. But of course, we as a healthcare provider, we should make sure that her pain management is done in a better way. So yes, even after cesarean section we can continue breastfeeding successfully.
Yes, ma'am. Thank you for that demonstration. Yes, it was really good, ma'am. Normally in NRP, we talk about normal deliveries and how we receive on skin to skin contact. We show that. But when it comes to cesarean section, we tell, but we still don't have an idea how to do it. I think even gynecologists, obstetrician should have workshop on this. LSES, how to receive, so that everyone is sensitized on it. Thank you for that answer, ma'am.
Raksha,
Now,
We must
Yes, ma'am.
also just tell in 30 seconds the recent
ma'am.
where the mother with burnt breast, bilateral burnt breast, breastfeeding beyond burns, how well we all were able to put the baby back to the breast.
Yes, ma'am.
And somebody was talking about tigers. We have a session on Let's Remember History where I'll be talking about tigers. Please attend. We have curated an excellent program all about the 9 instinctive stages, breast crawl and all that for all those people who are present. I think we are very grateful that on a Sunday, though it is only 45, we are doing well. Thank you. Sorry for the interruption.
Yeah, thank you,
Thank you.
ma'am.
Just here, I just wanted to add that even we've successfully breastfed 4 mothers who had come over my so many years. I have all documented with the photographs. Mothers who had bilateral, burns on the chest, and we could successfully breastfeed them. Over to you, Raksha.
Yes, ma'am. This is the last question of the panel to Dr. Amit Upadhyay, sir. Are the legal penalties prescribed under IMS Act sufficient to deter violation, or there need to be stronger enforcement and stricter accountability to protect breastfeeding, sir?
Dr. Amit, can you unmute?
I'll say this can
Yes,
be
madam.
answered
Yes,
by...
ma'am. Yes.
Sorry,
So can you please repeat the question once?
sir? Yes, sir.
Yes,
So
ma'am.
it's about the IMS Act again, sir. Are the illegal penalties prescribed under IMS Act sufficient to deter the violation, or is there need for stronger enforcement, any stricter rules from the side of the government and policymakers?
Yes, despite current restrictions under the IMS Act, visual and linguistic marketing continues to shape the choices of both parents and at times, the families and the doctors as well. So manufacturers increasingly use indirect marketing now through emotional messaging, digital media, scientific sounding claims. So that is mostly this is recommended by this body. Some body they make and they start marketing that this is by this body and the other. So healthcare professionals can proactively educate families about common marketing tactics. That is very important. And discuss breastfeeding benefits using clear, positive, evidence-based communication, rather than assuming parents already understand them. Normally, we don't have time to talk about breastfeeding, its advantages and disadvantages of using formula milk, which is the main problem. And some small amount of time given to them can make a large difference. So all clinics and birthing centers should have lactation counselors who can at length sit and explain it to the mothers. So policymakers should strengthen monitoring of digital marketing, social media influencers, online parenting platforms, and cross-promotion strategies. They should improve surveillance and reporting mechanisms for IMS Act violations. So if somebody is blatantly seen doing a IMS Act violation, then people can have courage to report it to at least to the body of like Foxy or IAP or NNF. And I've heard of FIRs being lodged against doctors for taking sponsorship on through the IMS Act companies. So that appears a bit blatant, but yes, that is how things are moving. So that is a big deterrent. We should support public awareness campaigns that improve media literacy and encourage regular audits of healthcare facilities to ensure compliance with IMS Act and baby-friendly hospital initiative principles. So the key message is restricting advertisement alone is not enough. Families should be empowered to recognize marketing influences and healthcare systems. And most importantly, the laws have to be stricter and enforcement of laws somehow has to be made stricter. And all of us in office bearers should train ourselves and our colleagues so that such violations do not happen. Thank you.
Yes, sir. Thank you, sir. And I thank all the panelists. If questions, that's all the questions are done. So if anybody wants to talk about something in particular, open to panelists.
Can I just make one comment? This is about, having a lactation consultant in the hospital. which is a brilliant idea. They are trained and they can give the time, they can do good counseling. But I see in many corporate hospitals, they allow only one visit to the mother for this lactation consultants. So what happens? Just the one visit of that little girl is no good. Now WHO and UNICEF has recommended that the mother needs 6 visits for the successful breastfeeding, 3 in the hospital and 3 in the community. So she just coming once, maybe baby's crying, sleeping, mother is in the pain. She will just do some counseling and go away. That is not going to end up with the successful breastfeeding. Another thing, if the senior gynecologist, the pediatrician, the administrator, they are more aware about this breastfeeding, the importance, so they can change the policies of the hospital, under their leadership, so that the hospital, that BFHI 10 steps, it will help to continue those 10 steps. Thank you.
Thank you, ma'am.
Raksha, I have.
Yes, sir.
I want to ask Mangalavani Madam, since she's done an excellent job, proved herself as a role model, as a logician. Ma'am, what do you think we can capture, how we can capture IYCF aspect with logicians, madam? That is the toughest job so far I have spent in last 2.5 decades. Can you throw some lights on that?
So how do we capture IYCF in obstetricians, you mean?
Yeah.
Most...
What do you think? Why do you think we have not made an impact? See, BPNI has started the World Breastfeeding Week themes from 1991, and it all started in Wardha with a holistic approach. And all of us have been working. See, all the stalwarts here. I don't see anybody who has not spent at least 2 to 3 decades in this field. Why do you think we have not been able to have a breakthrough? Though mother and child we call as one unit, MCH care, everywhere we go, the protocols all over the world, WHO, UNICEF say that, institutions say that, and we work together home to home. But why do you think this particular part, knowing the value, there is a lot of information, there is a lot of research, that this is the best? Why do you think we have not, madam? Please enlighten us on that.
I mean,
Sorry if I have troubled you.
Started in 2008 when I came back to India. I was abroad for 20 years with the intention of promoting breastfeeding, and I had such a hard time. And the doctors, the obstetricians used to laugh at me. अरे तुम उधर यूके से FRCOG करके आई हो और ये गाय का काम क्यों कर रही हो? Something like that. And in our hospital, the Ayabai does this job. So from that, and then nobody will come to your lecture, even 10 people won't be sitting there. So from that stage, I have come up to here. So what I think, breastfeeding is the time taking thing. That's looking at the mother and the baby. It is a time consuming. So, and there is a lot of skills, lot of knowledge one has to acquire. It is not that simple. Even if we say breastfeeding is natural, it is an acquired skill. And the health professionals, the gynecologists has to have this skill. Then only the success we can see in the near future for these babies. Another thing, I think even for pediatrician or for any health professional, the financial gain. What I will get, by doing this work. I do one surgery cesarean section, and to see the mother and the baby, it takes the same time. But if I see my economic gain, it is so much difference between the two. I think that also puts off many doctors, taking interest into the mother and the babies and breastfeeding. And another thing, our IMS Act is very loose. A lot of doctors are corrupted. And as Sandhya madam said, ki hardly, there is anything done about it. So there, I think we have to focus more about the IMS Act and the people who are breaking the laws, how we get around those. That is very important.
My madam, my good, I think I understood that. My concern is, with this current scenario, the solutions, what I feel, I may be wrong, or I may be,
Solution is at the
having.
government level. So government has to make compulsory that every doctor has to have every year so many hours of education. Every maternity unit has to have a BFHI certification.
But if they promote what we have requested to our Neelam madam, training all the medical colleges, we have to do correction there. The uniformity should come. Oneness, one language, one theme, one practice, one technique, uniform. Then if the colleges are trained, we are going to address the whole next generation of doctors.
Yes, next generation. Yes,
Yeah,
that
that
is
is
very
one. And
yeah.
we need just cooperation from OGCians. That's all. See, I have worked last 2.5, almost nearing 3.2 decades. If they give cooperation, we have done everything. That's how I worked in our institutions, and we are able to. And there should be encouragement to bring out the original data about what is happening in all colleges. Not many studies are coming up in medical colleges. So that should be the important thing. More so those high risk babies who go to NICU need that premature milk. Premature milk is ready from 7 months. Most of them do not know. And the quantity of milk that is produced in the first 7 days is so vital. We did the quantity of milk production in all the mothers who are antennatally educate them. Then you show them with the mother support group antenatally before delivery in the postnatal ward. Show the mothers who are already feeding successfully. That motivates them more. That makes them feel, oh, I can do it, they are doing. And a supporting nurse in all the 3 shifts, maybe in NICU babies, have beautiful results have given. We can do all this, provided it is not one individual logician or pediatrician. The system should be in place. Ramaya gave us the permission to train 12 nurses so that 3 nurses in a shift are available. That is one thing beautifully was planned. And even in NICU, no formulas are used now. That's like that. These practical things, micro planning should go on well. More so in a medical college. When PGs work under these circumstances, they will follow the same thing. We have to show solutions at all levels. Preemies, cleft lip palate, Down syndrome baby, mother who has a sore nipple, twin babies. All videos we have made where mothers permitted. We use these materials, but I'm able to make an impact to only the small number of young pediatricians who are looking for some thesis topic. We have given them, only they are working because they realized it. So unless somebody enters into this process and learns like you, I don't think the transformation or the Nagavalli will enter their body to transform to that version, madam. That's what I have found. This is my experience. I'm putting it across. Maybe I am incorrect, pardon me, but the
You are correct.
transformation happens only when they sit and do themselves.
Take the juniors, and also we are doing this IBCSC training, and there are a lot of gynecologists have enrolled in that. So we have about 15 to 20 gynecologist IBCLCs, though they have not taken seriously they're doing work, in this area, but hopefully few will emerge and the situation will change.
I have one more request with you, madam, since you're representing Foxy. Sorry, I'm again and again asking you. Please don't mistake me. Why can't we have one sensitization module in all your Foxy conferences all over India, madam? Let them get sensitized faster.
That is what
not happening.
In my inaugural talk, I said the same thing, that every conference, we should have one breastfeeding session. Because there are people sitting there. They don't come for the breastfeeding program, but when they're sitting for some other thing, let us put some sense in their head.
Yes, madam. Thank you very much for your inputs, madam.
Yes, ma'am. You can take over, and people are leaving to join into another meeting.
Okay, ma'am.
Thank
yeah,
you.
it was
I
a wonderful
joined another
discussion.
meeting, so I could not hear last 15 minutes. I'm here somewhere else to felicitate some people. So, Raksha and everybody, thank you. Take a good group picture, please.
Last 15 minutes, 1 minute discussion was involving Foxy and having one-day sensitization workshops from IAP to Foxy, madam. That's a very crucial thing. Sensitization, maybe we'll give more pathways to work out with them, madam.
Are you done, Raksha?
Photos, ma'am. 1 second, ma'am. Be there, ma'am. I will just take. Yes. Yes. Amit sir is not there from the panel. Not visible here. Done, ma'am. Taken photo. This was taken.
Thank you. Thank you. See you tomorrow, 3:30. Bye-bye.
Yes, ma'am.
Thank you.
All the messages, important ones, somebody compile. Raksha, today's messages, if not you, somebody compile the messages together in the end. Asha or Sushma compile and say very informative messages I got. I mean, what you said, Foxy, I heard, but I can't impress whether government should make it for medical and all. All that I mean, we'll put forward and see, because we are democracy. We can't be Hitler, but like she said, Sandhya, and that if you appreciate also, she said, give them incentive. I like that line also. And how milk bank, something can be done. As I said, I kept money aside. Nobody even applied for it. So if you all can talk to some milk banks, I'm happy to shell out couple of crores for milk bank if somebody is wanting to take it. But I can't take every responsibility. I can give you all, the entire team come together. You people be leaders, 40, 50, 60, whoever. But then I'm just your executive director. Executive is by name. Main groundwork you all do. Come out with a book, come out with this, milk banks, strategize, what is the space, how much you need, what all. एक SOP जैसे जो भी बनाओ. Because when I said, everybody in the GBM EB said, "Arey madam, what are you talking? It is next to impossible. How will anybody sustain? Even if you give them money, how will they sustain subsequently?" I don't know, many questions were asked. So I have no answers. You all come out. What is the development? What is maintenance? How much it is? All that you come out with some black and white paper. I'm putting this to Sushma to talk to rest of the colleagues, Asha, Malik. I can't do, but you all do. You will get the credit. I'll help you get the money. That's all I can say.
Thank you.
Thank you, ma'am.
Thank you, madam. Thank you for the opportunity inviting me to chair this thing, and thank you one and all. It was very nice learning with you all. Your innovative ideas, and especially from the gynecologist Ojitian version.
Thank you.
And all the seniors. Thank you, madam.
Yeah. Thank you, all the dignitaries. Thank you, panelists, Manglavani ma'am, Sandhya ma'am, Amit sir. And I also thank Asha ma'am. She is my mentor and teacher from PG. Thanks for the opportunity, ma'am. Tomorrow we have a very good session lined up. Gender and breastfeeding from father's perspective. So please join tomorrow also. Thank you all. We will stop the meeting.